Our next speaker will be speaking remotely. I think he's there, Paul Shekelle. Paul is director of the Southern California Evidence-Based Practice Center at the RAND Corporation, also affiliated with UCLA School of Medicine and the VA Medical Center in West Los Angeles. He'll be talking about some interesting instances of trying to synthesize evidence. So, Paul?
Yeah, I'm here. You guys can hear me? Roger?
A little bit soft.
I can't talk any louder, so you're going to need to turn your volume up.
Okay. Thanks.
I can hear Roger perfectly. Okay, so anyway, thanks very much. So, Ruth, can you go to the next slide, please? Yeah, so these are my disclosures, okay, and now the next slide. Okay, so thanks very much for this opportunity to talk. I want to say I think that there's really two criteria that must be met in order to conclude an intervention works. The first one's familiar to the evidence-based medicine frameworks, namely confidence of an association between an intervention and an outcome that's unconfounded by other factors. But equally, I think we need a mechanism for how the intervention is supposed to work. And I think both are needed. I think a real-life practical application of the need for both is seen in trials of homeopathy, which have met with skepticism despite occasionally reporting statistically significant benefits, as some skeptics have pointed out that in the dilutions being used, there may not be even a single molecule of the active substance in the intervention given to patients. Now, most of the topics for which I'm asked to do for reviews, as Roger says, through the center, either at RAND or at the VA, are biomedical interventions, and they have a very long backstory of development. And the how do we think it works question is not really an issue. There's a lot of basic science and physiologic evidence leading to the development of the intervention. But there are exceptions to this, and in these exceptions, I've used mechanistic evidence to help make the case for an intervention working or not working. Next slide, please, Ruth. So there are two ways that I've used mechanistic evidence. One is to extend the evidence of an effect from one set of interventions in populations to related interventions in populations. And then the second is to actually be the basic support for causal conclusions about an intervention and an outcome. And then the next slide, please, Ruth. And I'm going to illustrate this with two examples from my own work. In my experience, these examples are much more common when I'm dealing with patient safety or quality improvement interventions, but I thought for these purposes, for the purposes of this group, I'd talk about two biomedical interventions. And the first one was this. It had to do with, this is a topic that we did for AHRQ through the Evidence-Based Practice Center program. What is the evidence for the effect of bariatric surgery compared to non-surgical treatment of diabetes in patients with a BMI of 30 to 35 kilograms per meter squared? And the study inclusion were the typical kinds of things for this kind of a review. They had to be RCTs of patients with diabetes in the proper weight range, treated with surgery or non-surgical therapy, reporting any of a number of relevant patient outcomes. But when we did this literature search, what did we find? There were 0 randomized trials of patients in this population. So then that led to the question of what to do next. Should we turn in an empty review and say there are no eligible studies and therefore it's very low or insufficient what the relationship is between surgery and outcomes in this patient population? Or do we use other evidence to try to reach a conclusion? Next slide, please, Ruth. So what is this other evidence? Well, in this case, there were 2 randomized trials of surgery that enrolled diabetic patients, but the mean BMI was 37. So, in other words, not even half the patients had the BMI in the proper weight range. There was one RCT that enrolled patients with the proper weight range, but none of them had diabetes, but about a third of them had impaired fasting blood glucose. And between them, these 3 trials enrolled about 290 patients. Then there was an observational controlled study of patients with diabetes and a BMI in the proper weight range. And then there are literally uncountable numbers of surgical case series of patients with diabetes and BMI in the proper range mostly. And then lastly, of course, there's a lot of randomized trials of effectiveness of non-surgical therapies of diabetes, mostly with patients whose BMI is in the proper range. Next slide, please, Ruth. So what did these studies show? Well, in the 3 RCTs, none of which quite met the inclusion criteria. They showed higher proportions of patients achieved target A1C control treated with bariatric surgery or better fasting blood glucose as compared to non-surgical therapy, and much greater weight loss. Next slide, please, Ruth. The one observational controlled study of patients showed a much greater decrease in A1C and weight loss in patients treated with surgery. Next slide, please, Ruth. The numerous case series actually reported large percentages of patients with diabetes able to achieve blood glucose control without need for medications postoperatively in patients, particularly those treated with Roux-en-Y gastric bypass. And then last slide of this set, please. And of course, the many RCTs of effectiveness of non-surgical therapies generally show fairly modest results. The average effect on A1C of most hypoglycemic medications in the order of 1 to 2 percentage points, and of course there's minimal effect on weight. Next slide, please. So how did we use this evidence? Well, we reasoned that the best explanation for the results that we just went through is that bariatric surgery does have a causal effect on blood glucose control, both through a weight mechanism by improving diabetes control that way, and in the case of Roux-en-Y gastric bypass, by some alteration in biochemistry, metabolism of glucose uptake and processing. And given this conclusion, and given that the upper limit of BMI of 35 is an arbitrary cut point on a continuum, and that disorders of glucose metabolism are also a continuum, with IGT being a precursor to diabetes, we concluded with moderate certainty evidence that bariatric surgery provides better control of diabetes than non-surgical therapies for patients with a BMI of 30 to 35. Next slide, please. This second example is now about how we actually use the the mechanistic evidence to actually support the primary causal inference. So here it's what is the evidence for the effect of colchicine, NSAIDs, and oral steroids in the treatment of acute gout. Next slide, please, Ruth. So as before, these are the typical kinds of eligibility criteria. Had to be adult patients, had to assess an FDA-approved medication, report patient clinical outcomes, be an RCT. Next slide, please, Ruth. So what did we find? Well, there's only 2 studies of colchicine, and those are both actually relatively recently, so that when I was in medical school in the 1970s, at that time there were no placebo-controlled randomized trials of colchicine, despite the fact that it was the standard of care for acute gout at the time. There's no placebo-controlled trials of steroids for acute gout, and there's only 1 placebo-controlled trial of an NSAID, enrolled 30 patients. It's a non-FDA approved medication, and it is too small to really be able to draw any kinds of conclusions. So again, this left us, next slide please, what should we do? Should we conclude that the evidence is very low or insufficient and that we can't make any assessments, or should we use other evidence to reach this conclusion? Next slide please. Well, option A on that last slide was the path that was chosen by BMJ Clinical Evidence at roughly the time that we were assigned to this topic. Here is the relevant page from BMJ Clinical Evidence about treatment of acute gout, and you can see down at the bottom, treating acute gout, likely to be beneficial, colchicine, and then of unknown effectiveness, corticosteroids, corticotropin, and NSAIDs. Next page, please. And this is the exact text from BMJ Clinical Evidence at the time. We don't know whether NSAIDs reduce pain and tenderness in an acute attack of gout, although they are commonly used. And for colchicine, it may be more effective than placebo. And then for steroids, we don't know whether these things improve symptoms in acute gout. And for me, I mean, those things just don't hold any face validity, okay? So what else do we know about acute gout and its treatment? Well, first we know that the acute attack is caused by an inflammatory response to the deposition of urate crystals. And we know that these drugs are all anti-inflammatory treatments. We know that NSAIDs are FDA approved based on RCTs for quote, temporary pain relief of acute painful conditions, end quote. That doesn't mean that all acute painful conditions have been studied, right? Gout flares an acute painful condition. Next slide. We know that corticosteroids are proven effective in the acute inflammatory phase of other inflammatory arthropathies. In fact, the 1950 Nobel Prize in Medicine was awarded to that person, Dr. Hench, for the treatment of acute RA with cortisone. And then lastly, there are 6 RCTs that compare NSAIDS versus corticosteroids with no placebo group. So that is head-to-head trials. And next slide, please, Ruth. And all 6 trials report equivalency in outcomes. Therefore, we had to conclude that they were both equally effective or equally ineffective. Next slide. So we use this other evidence in our decisions about strength of evidence to conclude that the strength of evidence is high, that all 3 of these things reduce pain in acute gout. Next slide, please. So the things that I just described are things that we sort of developed within our own selves and our own group and published in those things that you see that were referenced at the bottom. But since that time, I've become aware of another group that's been thinking and publishing thoughts in this field. And here's one of the things that they've published from this group of people from Oxford and Australia. The evolution of evidence hierarchies, what can Bradford Hill's guidelines for causation contribute? Some of you may have noticed that I was using some Austin Bradford Hill criteria in those prior examples without actually calling it as such. Next slide, please. So these authors say that the Austin Bradford Hill criteria can be framed in this way: as direct evidence from studies that are either randomized or non-randomized that a probabilistic association exists. Number 2 is mechanistic evidence for the alleged causal process that connects the intervention and the outcome. And then number 3, parallel evidence that supports the causal hypothesis suggested in a study with related studies that have similar results. Next slide, please. And they illustrated this with this graphic here, and I don't think it's an accident that it's a parachute of a little man or monkey or something coming down to earth. And you can see that they have direct evidence as the big parachute, but then they have these 2 smaller parachutes, one on each side, mechanistic evidence on one side and parallel evidence on the other side, and then they have the Austin Bradford Hill criteria there in the lines. And the clear implication here is that as the size of these mechanistic evidence and parallel evidence parachutes get bigger, then correspondingly the size of the direct evidence parachute can be smaller for the little monkey to safely still parachute down to earth here. Next slide, please. And they then went on to then publish this article, Evidence-Based Mechanistic Reasoning, where they argued that next slide, please. They posited that mechanistic reasoning can itself be high quality or poor quality, and that examples where mechanistic reasoning has failed due to poor quality should not result in the conclusion that mechanistic reasoning is an invalid method any more than an RCT that failed due to poor quality means that an RCT is an invalid method. And then they go on to identify 2 categories of poor quality mechanistic reasoning: empty or partial mechanisms, which we can talk about more if people want, and probabilistic and complex nature of mechanisms. And so then the last slide. So I believe that mechanistic reasoning is a requirement to reach conclusions that an intervention works. In most situations, it takes a back seat to the role of empirical evidence in terms of establishing causation. However, there are certain situations where mechanistic evidence can be sufficiently strong that when combined with uncontrolled clinical observations, conclusions can be made with high certainty. In my view, such situations are characterized by the mechanism is strongly supported in all of its steps and the number of intermediate steps is small, that the time between the intervention and the outcome is short, that the difference in outcome between the treated and untreated state is obvious, and that alternative explanations for the difference in outcomes are far less plausible. And I'll end it right there. Thanks very much.